My name is Kayla Magruder, and I'm an admissions counselor here at the C. Scott Weatherhead School of Public Health and Tropical Medicine at Tulane University. And thank you so much for joining us today for our Public Health Discovery Seminar series. Today, we have Dr. Richard Priore, a faculty member in our Health Policy and Management Department that is here to present on making the business case for public health, aligning the mission with resources. Just really quickly, some housekeeping notes. We're going to listen to Dr. Priore's seminar, and then about the last 15 minutes, we will have time for Q&A. So at any point, if you have any questions during this seminar today, please put those questions in the Q&A and we'll answer them all at the end. All right, if you have any questions, please feel free to drop them. For me specifically, feel free to drop them to me in the chat. However, I will hand it off to you now, Dr. Priore. Thank you so much for joining us.
Thank you, Kayla. I really appreciate it. Thank you all for joining. I really appreciate it. Hopefully, this is a very thought-provoking and timely topic. And I look forward to your questions at the end. I'm going to start with a quote by Herbert Hoover, of all folks, not necessarily considered one in our history for fiscal responsibility. Recall from your 8th grade civics, he kind of brought us into the Great Depression. But he talks about how public health service should have some return on investment. That's a topic that I'm going to revisit shortly. But my goal is to inspire you to think and act differently, and the act is the important point. But I need to get you to think differently, the way that you've been looking at those of you who have or will have responsibility or influence over any type of public health service, program, service, entity. And it starts with 3 premises that I'd like you to consider and hopefully accept as we get started. The first is we have decreasing resources to support mission critical services. And this is not just in public health, this is also throughout healthcare. The second premise, I can get my mouse over here. The second premise is that translating their impact on the communities that we serve into a defensible bottom line justification, particularly in this climate, is challenging. And lastly, making an effective business case for those essential public health services and program is not just a nice to do, but it's necessary for survival. And towards the end of this webinar, I'm going to give you an example. I'm going to give you an opportunity to do some calculations. No extra charge on that opportunity. So a little bit about my background. I've now been at Tulane now coming up on 3 years as a full-time professor. I teach in the Master's in Healthcare Administration program in the Doctorate of Public Health. I teach finance and economics. My background in healthcare is in senior leadership roles in the military for about a decade, mostly overseas. Another 10 years working in hospitals and health systems, and then consulting. I stay active in the industry through an international consulting firm that I founded about 8 years ago. And I've been involved in teaching about 10 years, full-time teaching at the University of Minnesota, St. Thomas, and then my doctorate alma mater, Tulane University. I got my MHA from Baylor University, and I'm active and involved and a fellow in the American College of Healthcare Executives. So this is not intended to rub salt in anyone's wounds or be depressing. It's a reality check. And I hope that when I discuss these challenges and what you can do, remember, my goal is not just to inspire you how to think differently, but to act differently. These health challenges should be a call to action why we need strong leaders in public health. So in 2024, chronic diseases accounted for 7 of the 10 leading causes of death. And it's estimated that chronic disease in the United States accounts for about 90% of our almost $5 trillion annual health expenditure, and growing every year. We have a growing elderly population. 10,000 Americans are aging into Medicare every single day. By 2030, 1 in 5 Americans are going to be at retirement age. Um, in the United States, Black Americans have a life expectancy 5 years shorter than white Americans, and 1 in 5 rural residents report difficulty accessing healthcare. In 2024, 1 in 5 adults, it's about 21%, experience mental illness annually, and the rates are higher among those ages 18 to 25. It's about 33%. 2023, there were over 48,000 gun-related deaths in the U.S., so making firearms the leading cause of death among children and teens. In 2023, more than 111,000 drug overdose deaths occurred in the U.S., a record high, with opioids, mainly fentanyl, involved in over 68% of those deaths. And in 2023, the U.S. experienced a record 28 separate billion-dollar climate and weather disasters with public health impacts, including increased respiratory illness and heat-related deaths. And that one is near and dear to folks in the Southeast and New Orleans as we're getting ready to come into hurricane season next month. Okay, so level set with, and those are the main challenges. I'm sure others of you could list more challenges, but those are the primary challenges that we're facing today. And Einstein said, we have to think differently. An old boss of mine used to say, we have to find new ways to do old things. In the way that we created the problems that exist now, that current thinking won't satisfy solving those challenges. So with today is the 100th day of the current administration. And I have some notes here that I'm looking at from the American Public Health Association. They just put out a press release a couple days ago talking about the impending 2026 budget cuts that would devastate the Department of Health and Human Services, slashing 1/3 of the budget. And Kathleen Sebelius, who is a former Health and Human Service Secretary and the governor of Kansas, talked about the potential devastating effect that this would have. So the proposed budget cuts set to take effect this October, if approved, would, among other changes, reduce funding by 44% for the Centers for Disease Control and Prevention, CDC, 40% for the National Institutes of Health, and 19% for the Food and Drug Administration. The not-for-profit For Our Health has talked about that these proposed cuts will create immediate harm to health and food safety services that are relied on by all Americans, including children, seniors, and those in rural areas. So, like I said, the intent was not to depress you, but to make sure that we're on the same page with the challenges that we're facing. That's going to allow me to tee up next on what you need to do, what you can do to think and act differently to help address them in the communities you serve. So I think after all of those statistics, I think we need to acknowledge the serenity prayer, whatever religion or no religion that you have. And the important point of this is to understand the difference between the things that you can change and not change. There's a lot of anxiety, to put it lightly, in the U.S. And in the world with what the administration in the United States is doing. So within public health, I think it's important to understand there are things that you can change and there are things that you can't, and the importance is knowing the difference. And I think this is probably a good point for a quote from Charles Darwin. A lot of people think that he says, well, it's the strongest that survive. It's not, according to Darwin, and I hope you can appreciate this. It's the ones that can adapt to the change. So if anything, in the past 100 days, it may seem like it's been longer, there has been a significant amount of change and there's more on the horizon. So our ability to adapt to those changes, and as much as we can, anticipate them, will better serve the communities that we live in and what our respective roles are in public health and preserving and sustaining those. So what's a business case? Some of you may have had some experience. Some of you, this may be new. Some of you may think, well, that's what the business folks do. That's not my responsibility. And I'll say that this is everyone's responsibility. And you don't need an advanced degree to figure this out. Although I teach this in my classes, and I've written several articles that I'll make available. Anyone who wants to reach out to me, I'll provide my contact information at the end, I have a QR code that you can scan. It takes you to my LinkedIn, and you can reach out to me there, or my Tulane email address. And I'll have Kyla drop that in the chat so you all have it. It's just rpriore@tulane.edu. So, having invested a lot of time and energy in developing this work so that healthcare and public health professionals can do this, a business case is typically often ignored or poorly developed, and sometimes after the fact, after the initiative or program has been launched, then it's okay. Let's figure out what the business case is. What's it going to cost? What's the expected where the revenue is going to come from? So what it is simply is it just evaluates financial feasibility of a project or initiative, and it explores different scenarios: cost benefit, best case, worst case, likely case scenario. And it identifies a term that I'll introduce you to. It's in the articles that I mentioned: the cost of waste, the cost of doing nothing. If we do nothing, this is what the cost of waste. There's waste in everything that we do, particularly in healthcare. It's expected that about a third of everything is wasteful, which means it doesn't add any value. And that's a third of, a large and increasing annual expenditure. I mentioned $5 trillion. So it quantifies the qualitative value. I'm going to say that again. It's quantifies the qualitative value. It monetizes quality. So let's talk about value for a second. We talk about value, and there's two terms. If you take nothing away from this other than that quality, however you define that, some improvement. It could be clinical outcomes. It could be improving access for a historically underserved population. It could be safety, patient experience, service, employee well-being. Whatever quality is divided by cost, those two variables are inextricably linked. So the numerator is the leading indicator. It's the reason we exist. It's our mission. If you go to your respective organization's mission statement, we live to serve and support something in the communities. That's the numerator. However, and as the late Sister Irene Krauss said, no margin, no mission. And if you're not familiar with the term margin, it's the profit, the money that's left over. If there is no financial support, there is no mission. Everything that we do has some financial impact. Our salaries, programs, marketing, somebody is paying for them, if not a taxpayer, if it's a government service. Apropos of my Italian-American roots, Al Capone once said, you can get much farther with a kind word and a gun than you can with a kind word alone. Well, in this case, the gun is the business case. The kind word is often, this is our mission. This is essential. We have to do this. And in this current environment, that's the price of entry. When you have significant cuts and an administration that understands business transactions, if not, that's part of the culture of this administration. The gun in this case is, and here's the financial impact. Here is the return on investment of investing in fill in the blank program, prevention, service. If it was easy, everybody would do it. I said should not be this hard. And some of the most effective business case I've literally seen on the back of a napkin. But there are some challenges that you need to be aware of. And the first is there are data limitations, and I'll talk a little bit about how to overcome those shortly. And it's typically we either don't have the right data, we don't have enough data, or there's too much data. So data can be, if you allow it, a limitation to developing an effective business case. The unwillingness to take a financial risk. Well, we don't know what the financial impact will be. We don't know if this is going to negatively affect our budget or other programs. So you get the unwillingness. We are typically risk averse in healthcare and public health. And then how do you translate some quality improvement, whatever your proposed initiative, program, service is, into a measurable return on investment? And I'm going to give an opportunity to do that. I'm going to ask you, pull out your calculators, your Excel spreadsheet, for those of you who are big fans of Excel spreadsheets. I mean, who isn't, right? Your abacus. And we're going to walk through an application. a firm believer in experiential learning. The best way to learn something is to practice it. And it's okay if this seems a little awkward. I tell my students that you can learn something or you can look good. You can't do both. So it's okay to feel a little awkward, especially if you've never done one of these before. I'm here to support you. So this is based off and adapted from some real world data from the CDC. And this is looking at PID. So it's pelvic inflammatory disease. So this is a fictitious county, actually the county where I grew up in. Franklin County is is looking at an increasing prevalence of PID, pelvic inflammatory disease, which is results from sexually transmitted disease or infection. So in the past 12 months, there have been 50 cases. And in this example, the cost to the state, so these are Medicaid beneficiaries in this example, not private insurance. The cost to the state and by association to taxpayers is $21,000 to treat each case of pelvic inflammatory disease. And the proposed new program, the good idea is, well, we believe based on, you would hope, some evidence-based, some research, some data that's been done, that we can conservatively decrease these cases. So remember the value equation. The leading indicator is obviously the impact to the individual who suffers from PID, so preventing that. And then the denominator is cost, so the financial impact. And the expectation is we can reduce it by 30%. But the projected cost to get this new program going to achieve that 30% reduction is $250,000, $250,000. So funding for health programs has been slashed, and I set the stage for what's going on. So there is money available. However, the challenge is getting access to it. And like I said, the price of entry is this is a necessary program. It has some quality impact. And consider this. If you're able in that next breath to say, and here's what the projected financial impact is, just to register the surprise. It's not something that we're used to hearing. Think of any discussion that you've either led or been a part of where there is a registered need. And this is an economic challenge, right? We have unlimited wants and needs and increasingly scarce resources with which to satisfy them. So if you are a decision maker in a public health organization, state, federal, local, private organization, and you're trying to impress upon those why you need this, the second follow-up to this is the leading indicator. I call this hearts and minds, right? The heart is, and that's kind of the, like I said, that's the price of entry, why this is important to the community that's being served or impacted favorably. And then the minds is, well, this is the financial impact, right? Because there's only so much in a budget. And when those are being cut, the ability to help leaders prioritize those, this adds another very critical data point. So in this case, you have to find the return on investment within a year or less. Now, how would you go about doing that? This is where if I were teaching a class, I would open this up. I'd break you into small groups. But I'd like you to think about how would you put together the numbers that you have, the data that are available, estimated costs per case. That's the cost of waste, and that's what you're trying to prevent. The cases of pelvic inflammatory disease for the benefits of those who are at risk. And remember the prevalence is increasing, 50 cases a year, the cost in the new program, and the projected 30% reduction. How would you go about calculating the financial impact, the ROI? So if you were presenting this, the leading indicator is in here, something's happening. So I'm going to go and see if I can. Kayla, you're there? Are we getting
No one's dropped anything in the chat just yet.
okay. I'll give you just about 30 seconds to noodle this. If you were going to make a business case, those 4 pieces of data are all that you need really to get started. How would you present that? what calculations would you do? And I'm going to go through the math in a minute. Kudos to anyone who can get the answer. And if there are any of my former students on the call, well, let's just say.
We do have someone
All right,
that
what do you,
dropped in the chat. They
I
said
see.
cost per case multiplied by cases by year.
Yes, that's right. Now, what is it? We're going to go through the numbers. So that's exactly, it doesn't need to be any more complicated than that. Thank you for putting that in there. So what's the ROI? So it is the cost per case times the number of cases per year. It's a little over $1 million, a lot of money. And you know, the common, and I've done this in a lot of different scenarios, and it works well when you're looking at investing in, and I encourage you to use that term investing versus cost. Why? Because when you say I need $1 million for an investment in something, it it conjures the, well, there's a return from the investment in the expense. Again, unlimited wants and scarce resources to satisfy them. Versus if you say I need $1 million, or in this case, it's $250,000 as an expense, I'll probably never see that back. So if you're talking, particularly at senior level, somebody like at a state comptroller level that understands the finances, that kind of manages the purse strings. So you'd come up with a cost of waste, and that's the first call to action. And typically the response once you calculate this is, wow, that's $1 million of treating this particular pelvic inflammatory disease. And your estimated cost of the program, staff, marketing, whatever it is. And if you multiply the cost per case times the 30% reduction, you're talking about 327,000 and some change reduction in the cost of waste. And it could be more. And typically you would present this on a sensitivity graph. And that answers the what if. And it's just a graph that shows the variables, the reduction in the cases, and the financial impact. Again, setting aside, but notwithstanding the impact on those lives affected. So if somebody were to say, well, what if it's only 25%? What if it's 40%? What if it's 50%? And this is the opportunity where you want to try to underpromise and overdeliver. So if you think it can be 40%, then let's go with 30%, right? People will be much more impressed if you can over deliver on that. But in this example, let's just say it's 30%. And that's typically grounded in some research that's been done. By the way, if you appreciate the need to integrate quality and cost in the value equation, and you look to the literature, less than 1% in all clinical journals that are published have some mention of the financial impact of something. So you subtract the $250,000 cost for the program, the annual cost, from the projected savings, and you get a return on investment of about $77,000. And you can present that as a percentage, 23% return on investment. So that means for every $1 that is given to this program, you're projecting it's going to return $1 and almost 24 cents. Not looking at the last few months of the stock market, the average annual return of the stock market over 30 years is about 8%. So a 23.7 estimated return on investment is pretty good from a financial perspective. I'd take that bet every single day. So another way to present and look at the relationship between quality and cost, remember that's our value equation, is being judicious with increasingly scarce resources, being efficient and effective. And efficient is you're only spending what you need, trying not to waste it. So think top of license, think optimizing delivery, and it's effective. So whatever the program is, and again, this is where some previous research should give you, what has been effective, and particularly in the community that you're serving, should result in cost savings. Now, cost savings, if just in this example, if you're able to reduce expense, so the cost of treating pelvic inflammatory disease, you're able to cut the cost of waste by 10% on a $5 million budget. That's $500,000. That's bankable dollars. Those are dark green dollars. And then with that savings, you have some capacity now. So where you were spending the money to treat pelvic inflammatory disease, you can do something else. You can add new programs and services, immunizations, prevention, wellness, education. It gives you $500,000 to invest. So improving quality, in this case, it's a multiplier effect. It's $1 million impact. So high quality, efficient, and effective begets high quality. But change is hard, right? Change is very difficult. And if you're thinking, well, I'm pretty good with change, I'm a change agent, and I'll give you this test. And I wish I could see you because I suspect some of you would probably bristle a little bit. The test is this: whether you have a partner or you sleep alone, when you're home, I suspect you have one side of the bed. Think about changing sides. When you go to sleep tonight, sleep on the other side of the bed. Maybe a couple of you would, the anomalies, would be like, yeah, sure, no, it doesn't matter what side of the bed I sleep on. But for most of us, we're creatures of habit, and change is very hard. When you combine that with the previous statement that I made, that we are typically risk averse, we won't bet the farm on major initiatives, it makes it hard to get any initiative, anything new approved. So remember these numbers. I just shared them with you. We went through the calculation, and that should make sense to you. Cost of waste, it's $1 million. You're going to try and reduce the number of cases impacting those humans who are affected, 30% in estimate in this case, and save $77,000, almost 78, money that can be used for other things. And we calculated the percentage of the return on investment. But let's just say the leaders who control the financing say, look, we don't have 250,000. It's just not in the budget. Where's that money going to come from? So in this case, I'll introduce you to rapid cycle testing. And if you're familiar with Plan, Do, Study, Act, Plan, Do, Check, Act, taking a small test of something. So you don't have 250,000, maybe 2,500, right? You do a limited focus on a certain number, and you determine what you're going to measure. So we're going to measure the impact, and let's just say it's a combination of education and training, and marketing in communities that are being affected, in areas in the population, target marketing that are being affected by the increasing prevalence of pelvic inflammatory disease in this example. So you're going to test that on a much smaller scale. Could be $2,500. In a large organization, $2,500. Maybe if you're persistent, the controller or the CFO would maybe just write you a personal check just so you stop bugging them. $2,500. What are you going to do with that? You're going to test it on a baseline of data. And without getting too nerdy, all you really need are 30 to assess this. 30 data points when you're testing an experiment. This is the scientific method. And 30 is statistically significant. Then you run the test. You look at the results. So you have a pre and a post test. That gives you a control chart. Ideally, that would say before we had this intervention, this program, this was the rate of PID and the cost. And then post, right? And you're presenting this scientifically, but it's hard to argue with the data if you run it unbiased. And then you repeat as necessary. So I remember attending a fellowship for human-centered design in Stanford University, and it was their design institute, the Hasso Design Institute. And I remember one of the instructors saying, date your ideas, but don't get married to them. And we get emotionally attached to things. So we have to be able to recognize that not everything that we're going to try is going to work out. And this is where the comfort with failing and recognizing that failing is a part of the learning process. So if it works and it achieves the 30% reduction or better, then hardwire it into the program, or possibly it may need some modification. Maybe there were some cultural sensitivities that need to be addressed, language barriers, how the information is being communicated to those to prevent the disease. And if it doesn't work, it's okay to accept it and move on, right? Reject bad ideas early. And it's like Thomas Edison said, I didn't fail. I just found 10,000 ways that how not to develop the monofilament light bulb. So fail early, often, and small. And you can do that through rapid cycle testing. And it helps you proof the concept for a larger initiative, but it allows you to come back and say, look, we tried this on 30, and this is what the impact was. This was the impact on quality and on cost. That doesn't mean you're going to get the $250,000. It's not a guarantee. I don't want to um, be misleading that anytime that you present a business case, but consider in the rooms where there have been discussions of competing interests, the ability to say, here's the impact on this community, and then here's the financial impact. And we've tested it, and it's a better than 30% reduction in the cases and this much savings. And those are dollars from the savings that can be used for other programs and services. I said that I would talk about the data as one of the primary limitations. And in public health and in healthcare, we've been accused of being drip, data rich and information poor. We collect mountains of data. And the challenge is we get into paralysis by analysis. So I'll use the example of the Legos, the loose, unsorted Legos, organizing them into colors, arranging them and arraying them and presenting them visually. And in some cases, data are viewed as a means to an end. And in some cases, they're viewed as the end. And in this case, it's what you do with the data to help tell the story. Data should tell reasonably accurate, and there's no such thing as perfect data, but it should tell a compelling story to create that call to action. Sometimes that may be through qualitative, telling the story of a specific patient who had PID and the impact on their lives and being able to be productive and have good quality of life. So it doesn't necessarily need to be quantitative data. The best mix of storytelling and quantitative data are the most impactful. So I'm going to start wrapping up because I'd like to leave some time for questions and comments. Don't compromise good for perfect or good for great. Try to avoid the paralysis by analysis. If you're waiting for perfect data, it will never exist. Sometimes data are used as that end. Well, if we only had more data or the right data, it's okay as you create the business case to say this is a work in progress. And as more or better data become available, we're going to update this. Second, the cost of waste is an important call to action. $1 million annually to treat pelvic inflammatory disease. And then with that, you're able to develop a conservative and defensible business case, monetizing quality to justify and senior leaders being able to prioritize resources. And then lastly, the ability to pilot test, to take a small sample of something to proof the concept, work out the wrinkles, either hardwire it, modify it, or reject it as a bad idea before you look at a larger initiative. Like I said, I will share, I'll put in the chat my email, and then I have a QR code. There are some additional resources available. These are not publicly available, but I am able to share them with you. This was through it's a closed journal. It's not a public resource. A couple of years ago, there was a series of 4 articles published in the Physician Leadership Journal, but it's as relevant. It walks through the entire process from making the business case, monetizing quality, linking quality and costs. And these are short, 3-4 page articles. It's a pretty light lift, good bed table reading. And it walks through this entire process in a lot more detail than what I've covered in the last, 35 or 40 minutes. It's also a chapter in my book. Shamelessly, I'm promoting my book that was published a few years ago. I donate all the royalties to the Health Administrators organization at Tulane. So there's the QR code. if you take a picture of that or use your QR reader, that should take you, and I tested it this morning, right to my LinkedIn page. And you can shoot me a message there. You feel free to link in with me and I will share those articles with you. I just can't, I can send them, I just can't make them publicly available by posting them on a website. But since I'm the co-author, I can share them with you if you have an interest. And then I look forward to any comments or questions that you have on anything that I've shared or any specific examples. So I'll stop there and end the show. Kayla, what do we have for
Yes.
questions or comments?
Thank you so much, Dr. Priore, for that seminar. I thought it was excellent. I'm sure we have some others who felt the same. Now, if you have any questions, please feel free to drop them in the Q&A or in the chat, whichever is more comfortable for you. I see we have a hand raised. Unfortunately, we can't allow you to come off of mute at this time. However, if you drop it in the Q&A, we'll be able to answer any questions you may have. Okay? It looks like we do have a question in the chat or in the Q&A already. Um, how do you recommend bringing up the initial conversation of addressing waste if not in the healthcare realm?
So that's a great question. Again, we often talk about waste, and if you've been in any organization, so my background is working in hospitals, and there's typically a pretty elaborate dashboard that looks at all of your quality indicators. And in one of those articles, I talk about how do you integrate quality and cost. So you have on there, for example, and again, this is a healthcare example, you have the number of typically human involved, human related error, you know, that happens in healthcare. So Claudes and CLABSIs and C. diff and MRSA, community acquired or hospital acquired infections. And from a healthcare organization's perspective, the costs to treat those are pretty substantial. Usually increases the length of stay in a hospital, and whether it's a government payer like Medicare or Medicaid or a commercial payer like Blue Cross or Aetna or Humana, they don't pay any more for those mistakes, and it happens, very complex procedures. So framing the waste question without putting anyone on the defensive is it costs additional resources to the organization that one, you're not reimbursed for, that you don't get extra money for the cost of waste, and two, and this is the important part, that it could be used for other things. So the first time you do one of these, it can be a little awkward. So it could be a chart audit. It could be looking at literature of published studies, or it could just be what's your gut check. So that number that I used, the 20 some odd thousand for PID, was a number of studies that I looked at. But you would want to bring that to your own organization. And I'm not sure who asked the question, but tell me if I'm that I'm not wandering too far off base. So the initial discussion about everything that you do or fail to do has some cost associated with, and particularly if you are serving some population. So it could be immunization. What's the cost of, and it's typically of not doing something. What's the cost of not having an 80% herd immunity for a flu vaccine or for COVID? And then you could say, well, studies have shown, or maybe even your own data that said those who, if you don't, the likelihood, particularly for at-risk populations, elderly or those who are immunocompromised, the likelihood of being exposed to something that is going to potentially increase mortality, the death rate, or morbidity. So they're in the hospital for a number of days. And again, setting aside the importance of the impact on that individual's life and their well-being and their quality of life, what is the cost to it? So talking about the cost of waste is an important way to start framing the discussion. And throwing out a number, without some reliable or valid justification for it, can potentially undermine the case if you just make up some number. In this case, we did a calculation. It was a relatively conservative cost per PID times the number of incidences. We know that, and that's the cost of waste. Could you completely eradicate that? Could you get down to zero? Maybe, but at what cost? So there is a trade-off, and that's what we talked about. What the business case allows you to say, well, okay, what if I gave you 300,000, or what if we had to cut that to $200,000? What could the impact be? So again, it's the waste, the impact, and then what could you do with that? It's almost like getting money that you didn't have before. Remember that what is it, $78,000, I believe, that can be used for other programs and services to invest in. So if I did not answer your question, if I wandered off, please bring me back. It was a question that was asking about, and it's no longer in the chat. Question about how do you frame the initial waste, and sometimes just asking that thought-provoking question: what do you think it costs for this process that is wasteful, whether it's in time or ineffective treatment? Other questions? I don't see anything else in the chat, Kayla.
Yes, I don't see anything else either. If you have any of those questions, please, feel free to drop them in the chat. We'll give it a couple more minutes to answer any outstanding questions from
And
today's
Kayla,
segment.
can you put in the chat so everybody has it, my email address, if they want to reach out to me with a specific question?
Yes, absolutely. I'll drop your faculty bio, which will
Yep.
it'll
Yep.
include this email address and other helpful information of what Dr. Priori does here.
Yep, and I would be welcome if something that you're struggling with. Like I said, I've been doing, different business cases in different settings for over a decade. And knock on wood, I haven't found anything. I mean, there's when you're looking at the financial impact, there are, what I would call, the dark green dollars. That's a bankable dollar. And then there's, it gets, a little lighter green, like, well, what is the impact of improving reputation? What is the impact of burnout and turnover? Um, and if it's something that is interesting to you and you want to look at that in your organization, I would encourage you to consider the publication again. Less than 1% of all clinical journals published in the world have some discussion of the financial impact. And like I said, if you take nothing away, then cost and quality are inextricably linked. You can't talk about one or impact one without the other. Then consider contributing, because there is a definitely a blind spot in our industry of looking at the value equation as quality divided by cost. So
We did get
am
another question, Dr. Priori. If you look
I
in the
looking in the
chat,
chat? Okay, yep.
yeah.
I'm going to butcher your name. I think it's Oladayo. Thank you for putting my bio in there, Kayla. How can help business leaders build a compelling business case for innovative service models such as digital health platforms when the evidence base is still emerging and traditional funding mechanisms favor established services? That's a great question. And anything you can start with a business case, and it starts with, okay, it's going to cost something to do this in technology. And there's lots of great published studies that look at the impact of the electronic health record. So any type of technology. So you have to answer the question, what's going to be the impact? And again, looking at the two parts of the equation, quality. So any new technology, so putting on my former hospital CEO hat, there were lots of vendors and individuals that wanted to introduce something. So I would have to ask the question, okay, it's blue now and it's going to this version is red. What else is there? And hold the vendor accountable to say, okay, this is what the impact is going to be. We're going to reduce hospital acquired infections. We're going to reduce the length of stay. We're going to improve something, right? What is the cue? And it's not enough in my mind as a management scientist to say, okay, well, that's good enough for me. I need you to help me. And maybe we partner together and do a pilot study. All right, we'll take, 100 employees and we'll do a survey, right? This doesn't have to be a year long. It doesn't have to be an IRB approved study, but we're going to test some hypothesis, some theory. And the example that I gave in the webinar was that implementing this new program was going to reduce the prevalence of PID by 30%. We're going to test that. Maybe it's more, maybe it's less, but we're going to find, and that can be in a short period of time. So you have to be able to come up with some defensible evidence that shows the impact of investing in something, right? Invest versus the cost is going to have some return on investment. And remember that return on investment is looked at in two variables. What's the impact on some quality measure? Once you've got that, then you could say, well, what is the cost of bad quality or the cost of doing nothing? And if I am looking at it from a business perspective, the cost of investing in that new technology should outweigh, or at the very least break even, what the cost is and reduce it. And if I say I'm still not convinced, then I would say let's partner together and do a pilot, right? Mutually beneficial. So the vendor says we're able to show that this had an impact. We had a real environment where we could test this, and I get the benefit of improving some level of quality, clinical outcomes, patient safety, patient experience, prevention, wellness. So hopefully that answered your question. I really appreciate it. It's a very common one, and you have to start somewhere. And like I said, don't compromise perfect for good enough. Right. More data as they become available can be added to your business case. Like I said, the best ones I've seen on the back of a napkin. This is not to be confused with a business plan that you would take to, maybe some venture capitalist investors, 100, 200-page business plan. This is a business case, but it recognizes first the leading indicator, quality, and then the lagging indicator, what's the financial impact, cost or revenue.
Thank you so much for that, Dr. Priore. Oladayo has dropped some additional comments in the chat specifically for you, so we can take a look at that as well. However, I do want to ask again, if anyone has any outstanding questions, we'd be more than happy to answer them in the next couple minutes. Please feel free. You can drop them in the Q&A, or you can also drop them in the chat.
And I will send you those 4 articles. And anyone else who wants to email me or connect with me on LinkedIn if you're interested in them. My hope is that they would be thought-provoking. The idea of publishing something is that you could take this back to your own professional environment and replicate it. And I encourage you to do that. So that's the whole point of doing this webinar today.
Well, all right. If we don't have any additional questions at this time, I've dropped Dr. Priore's faculty bio in the chat. I will drop it once again, just so that everyone has access to it. Please feel free to connect with Dr. Priore, as he said, either on LinkedIn or via email. You can find his email in this faculty bio on our website. If you have any questions for me specifically, anything regarding admissions requirements, please feel free to email me at our SPHTM admissions email address. And I want to thank you all so much for joining us today. Dr. Priore, I want to thank you so much for joining us. We did have someone drop in the Q&A. Thank you so much for this seminar today. So again, Dr. Priore, thank you so much for your
Thank you
time
all.
and joining us. Thanks, everyone. Have a great
Thanks,
day.
Kayla. Take care.